Hello and welcome everyone. Today we'll be doing an important journal review. This topic is very important in the current context. It is about the common longitudinal ICU data format for critical illness research. Now, ICU is an ideal place for using data science because we are always collecting a large amount of patient information, most of the times manually, and in many places we have the electronic hospital records also. So each ICU is documenting its heart rate, blood pressure, the ventilator settings, the medication doses, sometimes hour to hour, and if you have electronic, then it can be even minute to minute. So the databases that we have, like the Mimic, they are widely being used because they are large anonymized ICU data sets. Artificial intelligence is already being used in the ICU for early warning systems, that is alerting the patient that a patient is getting worse, optimizing our resources, allocating beds and ventilators, making treatment recommendations tailored to that particular patient. Now, despite this, working with ICU data is difficult. This is because of various factors. The factor that the data is extremely complex, that many factors influence each other. So you have a ocean of data inside the ICU, and each minute is giving me more and more data. So the information may be incomplete or stored in a different format. So that, say for example, we try to include the data of 3 ICUs and try to make some data set. It becomes difficult because someone is storing the heart rate as HR, someone is storing it as a heart rate. So these subtle differences can make a lot of problem when you are trying to combine the data and analyzing it. Data is often captured for routine care, like what we do in our ICUs, but they are not really maintained for research purposes, which can lead to errors and missing out on the details if you're trying to convert that into a research project. So each hospital or the institution may store the data differently. As I said, a simple example of heart rate. So even if you're using electronic, the storage can be totally different. As I've already said, now to solve this problem, a common data model was created to standardize and organize the electronic hospital records across the hospitals. So OMOP helps bring the data together in a consistent way, making research across multiple centers possible. So see, heart rate, blood pressure are just 2 parameters. Like that, we have around hundreds of parameters which are coming in, like labs. We have the patient information, the diagnosis, in imaging. So a lot of things are coming in, a lot of data is coming in. So how can we organize it in a way that it will be used for? So OMOP often doesn't capture the ICU specific details like various ventilator settings in a consistent and a detailed manner, which limits its usefulness for critical care research. The authors propose a new data format called CLIF, which is the Common Longitudinal ICU Data Format. The CLIF is an open source tool designed to make the ICU research easier, more reliable, and reproducible. It collects minimum set of essential ICU data points in a clear, clinically friendly way. CLIF is meant to work alongside the existing systems and not replace them. So, what are the practical challenges to EHR data science in the hospital? Now, EHR is one aspect. It's not that you cannot do it with your manual thing as well. So, both can be done. Obviously, it will require someone to input that data from the manual records into the e-records. So, if that part can be done, this thing can also be done in those hospitals who do not have the EHR system. So the challenge is the complex longitudinal data with different frequencies. Now that is important because some investigations are done on a daily basis. Some are done after 4 or 5 days. Vitals is something which is coming every minute, or if you're doing manually, probably every hour. So this difference in frequency, how to understand this, how to input it into our data so that it can be analyzed becomes very important. Next, you have interdependent data and temporally dependent data, which is complex care processes which implicitly embedded in the presence and absence and frequency and content of the structured data. So a continuous neuromuscular blockade requires invasive mechanical ventilation. So that's these two are correlated, they are interdependent. Sepsis onset is defined by a complex temporal heuristics involving the sequencing and timing of antimicrobials, infectious tests, and abnormal physiology. So, from this data set, if you want to find out when did the sepsis start, say for example, you want later on to do a study where you want to say, I want to see how long after I am giving the antibiotic and how it is affecting my outcome. So for this, I need to find out when did the sepsis happen, even if I do have the hourly data. So this is a very complex way at which point should we define that sepsis has actually set in. These things are easy to say or write down, but actually doing it in Excel sheet becomes very difficult. The inefficiency and inaccuracy of the data. Many bedside measurements require manual recording, as we all know, and so the human validation is important. Many of the times, because of fatigue, they will write average values, which can make your AI interpret these in a very different way. So how we can remove the human part and make it more automated and still consistent becomes the major problem. We have complex data storage. Where are we storing? We have multiple places. The ventilator is storing its own data, the lab is having its own data, the monitor is storing its own data. So how can we integrate everything so that we have a singular place where we can have the data integrated becomes a major challenge over here. And obviously you will have your local idiosyncrasies, your local ICU practice, your own way by which your sisters or nurses are measuring and recording their data, your local protocols which may vary from place to place. So when you're trying to do a multicentric trial, it will be difficult. You cannot, it will be, when you're trying to make a very large data set, to organize it and to make it fit it will be difficult. So what methods they actually use? The CLIF consortium brought together ICU doctors, data scientists from different US based hospitals to tackle this particular problem which we are discussing. They met online starting July 2023 to discuss the real world challenges that we face and to find some actual practical solution. The goal included making a data format simple, which is consistent, easy to scale. Privacy is important because preserving is vital, and open source. The main principles are the data should be organized in a way that makes sense to the clinicians. The data elements must be consistent and able to be combined across hospitals. The format should adapt easily as the medicine and technology evolves. So it cannot be a standalone and a fixed set of information. It cannot be like that. Federated analysis, the research is done locally at each hospital to keep the patient data private, only sharing the summary reports. It should be open source and follows the NIH FAIR data guidelines, which is findable, accessible, interoperable, and reusable. Minimum common ICU data elements, that is the MCIDE. The common data element is a standardized way of recording a specific clinical detail, for example, a blood pressure. The CLIF includes the minimum set of things that are essential in the ICU dataset and should be clearly defined. For example, we have something called the vital category, which will include the heart rate, the blood pressure, the respiratory rate, etc. The data is stored in two formats: the original label, that is with the label name, and the standardized category, that is the lab category. For example, lab hemoglobin automated is the original name. However, it is mapped into hemoglobin, which is standard category. So this lab hemoglobin automated can be different in different hospital, but when it is mapped into this form, it will be always hemoglobin, so that it can be standardized. This helps with both quality control as well as standardization. Because this type of idiosyncrasies will be there in different hospitals, you cannot totally eliminate them. You have to ensure that they are mapped in a proper and appropriate manner. Structure and storage. The CLIF organizes data into 20 tables, each focusing on a specific ICU detail, that is vital, lab, medication, and etc. These tables are linked by patient and hospitalization ID. The format can be used in SQL database or as flat files, making it flexible. The public resources are provided for implementations. Now, what is federated analytic approach? Unlike databases like Mimic 4, if any of you have used, you can see that it combines all data in one place. CLIF uses a distributed approach. The main site writes the analysis code and shares it with the other sites. Now, each hospital runs the code on its own data and shares only the summary result back. The main site combines this result to give a final analysis. No individual level patient data leaves the hospital, protecting the privacy. This approach allows collaboration across many types of ICUs, increasing the generalizability. So this is what is the CLIF. Here you have the patient and the hospitalization IDs, and then you have the various events and data that are recorded, like vitals, scores, dialysis, intake output procedures, like that. You have various things which are mapped, and each box that you're seeing is a separate Excel sheet. All this Excel sheet will go into the SQL file and it will be analyzed at the primary center. So the CLIF consortium, they did this in 9 US health systems, 39 hospitals, 1,11,000 patients, and the patient population was similar in age, 61. Sex was mainly male, but had a wide range in racial diversity. And 39% of the patients received invasive mechanical ventilation. Hospital mortality was 9%. Additional clinical data like vasopressor and SOFA was used. They did two type of analysis, try to see how it was working. They did an AI model for predicting ICU mortality. The model used light GBM, a type of AI, to predict in-hospital death using the first 24 hours ICU data. The most important predictors were lowest albumin, highest AST, lowest pulse rate, lowest diastolic blood pressure, mean IST levels. So this was the ROC curves and the calibration plot and the decision analysis curves. These were the various hospitals, and they tried to predict the mortality in them, and they could find a decent amount of area under the curve. But now if you compare it with Apache only, it is just about similar. So we need more data coming in and more such analysis before we can actually make this into something. The area under the curve, the best was 0.81 and 0.73. With Apache 2, it's somewhere around 0.75. So nothing much has changed, but then it just shows that we are going in some kind of a direction, probably with more data coming in and more centers coming in and more countries coming in. Probably we will have more better information. The next was the temperature trajectory subphenotype. They analyzed all ICU admissions from 72 hours temperature trend to sort them into 4 groups: the normothermic, hypothermic, hyperthermic, and hyperthermic slow resolvers, fast resolvers, and they combined the data of all the sites. Most patients were normothermic, hypothermic was less, and slow responders and fast responders are given 16 and 8%. The hypothermic patients were older, the slow responders were the youngest, and this was the trajectory they pointed it out. So basically they were trying to predict what was going to happen. So outcomes was, in slow responders, the highest rate of invasive ventilation was seen. Normothermic, hypothermic patient had the lowest ventilation rates. Mortality was lowest with normothermic, highest with the hypothermic. Slow responders was around 20%. After adjusting for the age, sex, race, and ethnicity, the slow responders, fast responders, and hypothermic patients were linked with higher odds of needing ventilation and higher mortality compared to a normothermic patient. CLIF was created to turn the complicated ICU data into a simple, consistent format so that the research is transparent, reproducible, and easy to compare across hospitals and countries. It's open source, so anyone can use it. Clinicians and data scientists can work together to define and refine the ICU data set that is collected. In the case 1, the model worked well in hospital where it was built, but obviously the accuracy changed at other sites. The decision curve analysis showed that the model would help with the decision making, but it needs local validation and possible adjustment before being used in the ICU settings. So the takeaway is that the mortality prediction tool must be tested and, if necessary, recalibrated for each hospital before usage. The study 2 is temperature trajectory subphenotype. The model grouped ICU patients based on the temperature changes. Hypothermic low temperature patients had the highest mortality, and a finding seen before in the sepsis studies. Hypothermic slow resolvers had the highest rates of ventilation and death, suggesting this group needed early attention. And using such subgroup identification can help target care to those who need it the most, possibly improving the outcomes. So all this thing looks very good on paper, but there are limitations, which are that implementation requires expert help. You can't just do it on your own. Mapping the data from different hospitals is difficult, especially the labs, the vitals, the ventilator settings. The team is making the tool to help hospitals do this more easily. No real FHIR integration has been done with any system as of now. It is a global data standard, and linking CLIF to FHIR will enable live data sharing and future bedside application. Now, the way patients were picked may introduce bias in future. CLIF can use physiological and treatment data to better define who is actually critically ill, not just where they are in the hospital. Manual labor-intensive process, current federated analysis needs people to run scripts, check data by hand. Work is ongoing to automate these processes. This is extremely difficult project. It's not something which is easy, because you have to cross-check all the data that has been collected, and then only the algorithms will work. It's still evolving. New tables are being developed, new code status are being developed. This will allow better research in finding out the cause of death and helping in end-of-life care. Limited public data sharing. So far, the team is making public tool to convert the Mimic4 into CLIP format, so outside the researchers can use this format too. Eventually, the hope is to release a de-identified CLIP following the example of Mimic and Amsterdam. Thank you for your patience.